you. All right. Well, welcome to today's webinar, Community Paramedicine, Reaching into Your Community. And my name is Deborah Lane, and I am a program specialist with the Community and Population Health team at Rural Health Innovations, which is a subsidiary of the National Rural Health Resource Center and a nonprofit. Together, RHI and the center are the nation's leading technical assistance and knowledge centers in rural health. In partnership with the center, RHI is able to enhance the health of rural communities by providing products and services that focus on excellence and innovation. We are pleased to be providing this work to support Minnesota critical access hospitals on their journey to population health through a subcontract with the Minnesota Office of Rural Health and Primary Care and the State Flex program. Community paramedicine is a field of healthcare delivery in which paramedics and emergency medical technicians become certified to provide additional services to patients outside the scope of traditional emergency and first responder services. This concept is in the early stages of being adopted by critical access hospitals around the country. The goal of these programs are to increase access to primary care for medically underserved populations and to reduce avoidable use of emergency care resources. That's why we felt it was important to bring this information to you. Before we turn it over to today's speakers, we have a poll question that we would like you to answer. Keely? All right. Thank you all for answering those questions. I would like to introduce you to one of my colleagues at the center, Nicole Clement. She is a program specialist on the Technical Assistance and Service Center, or TASK team. Nicole's area of specialization is EMS. So, Nicole?
Hi, thanks, Deb. So as Deb said, I'm Nicole Clement. I work on the TASK team here at the center. I've been here for 14 years, and 12 of those years have been focused in the Technical Assistance and Services Center. So providing technical assistance to flex programs around critical access hospitals and really all kinds of things related to rural health. But for all these years, and really especially more so in the last bunch of years, I've been very focused on EMS and especially in rural areas. So we're going to talk about community paramedicine today. I invited a couple of people to join me. One is Jonah Thompson and the other is Joel Beiswanger. So a little bit about both of them. Jonah Thompson is the Mobile Integrated Health Operations Manager at Allegheny Health Network in Pittsburgh, Pennsylvania. He's been a full-time community paramedic since 2013 with 2 large health systems and is currently serving on the International Association of Flight and Critical Care Paramedics Board of Directors as the community paramedic representative. And then Joel has been the president and chief executive officer at Tri-County Healthcare here in Minnesota since 2008. Tri-County Healthcare is a 25-bed critical access hospital with integrated clinic services located in Wadena, Minnesota, providing services to a population of 23,000 in the central Minnesota counties of Wadena, Todd, and Ottertail. As a full-service rural community health provider, TCHC operates with a medical staff of 40 community-based providers, which consists of physicians, nurse practitioners, and physician assistants, along with 450 employees, operating services at 10 distinct locations with an annual budget of $72 million. His experience also includes time as CFO. Joel earned a Bachelor of Business Administration degree with an accounting emphasis from the University of North Dakota and a Master of Healthcare Administration from the University of Minnesota. He attained designation as a CPA in 1994. So all kinds of different perspectives there. We are going to start with Jonah, who's going to talk to us a little bit about what community paramedicine is. And then I'm going to share some key strategies for implementing sustaining CP, community paramedicine in rural communities. And then we're going to have Joel talk about his experience with community paramedicine from the hospital perspective, the strategic perspective of hospital leadership. So with that, Jonah, I will turn it over to you.
Thanks, Nicole. Let me get this up. All right, so everybody got my screen. So thanks for inviting me to talk again, Nicole. And really, this is a little bit about my story and a little bit about kind of the overview of what both these two terms, mobile integrated health and community paramedicine, have started to come to mean here, both as it applies to rural communities as well as it applies to a subspecialty that's emerging across the country with a lot of international parallels and partners. So a little bit about my background. I've been involved, again, as Nicole mentioned, in community paramedicine with two different large mobile integrated health programs since 2013. And for some historical context, in 2013, we were probably looking at about less than 24 programs across the country that were really structured and defined as MIH programs, though admittedly, EMS agencies, public safety agencies have been engaged in a lot of the different component activities in bits and pieces all over the place for a very, very long time. So I got involved full-time in 2013, was one of the first board certified community paramedics in the country. A couple years later, as that started coming out, got the opportunity to go and start up and run another one. And my experience has been with two large health system-based CP programs rather than those at the community EMS agency level. And as we'll touch on, MIH and community paramedic solutions are very much local solutions to local problems. But where these all came from, the original conversations that drove all of this came out of a lot of the rural health initiatives kind of going on in the early 2000s, where this conversation really started. Things have evolved quite a bit since then, but that doesn't change the applicability or the need to address some of these barriers to health, barriers to self-management that exist in the rural communities, as I'm sure you're all very, very well aware. So to get into this, I'm start with a story, because stories are great, right? And we had a kind of a late middle-aged older woman that generated quite a few 911 calls in a very short period of time. We're talking about 30 plus calls inside of, say, a 6-month period. So not the worst offender for reaching out to that safety net, to calling 911 that folks, especially folks living in urban areas, have seen, but certainly one that's going to raise a lot of red flags. Why is this, this person struggling quite a bit? And all of her calls seem to be related to diabetes related or diabetic related issues, but they were odd because they weren't all the same type of diabetes related issues. Some of these were glucose control, where her blood sugar was either very high or very low. In many cases, it was high. A lot of times they were related complaints, complaining about things like just not quite feeling well, feeling a bit dizzy, but her blood glucose was just fine. And she kept getting admitted to hospital, probably 2/3 of the time that she was transported by EMS to an emergency department. She ended up staying, typically for, again, blood sugar management, very often because it was high. Low blood sugar can be addressed a lot more quickly in most cases. And everyone was trying to talk to her about her diabetes. They were talking about, have you followed up with your endocrinologist? Are you checking your blood sugar? They're trying to refer her to nutritionists. And none of it ever really seemed to stick, and nobody could figure it out until the paramedics who kept showing up at her house realized a few things. From call to call, there were certain just things in the home that stood out, that were unusual, that they started to pick up on. They realized that the pile of things on her stove, the stack of newspapers and boxes and magazines, never changed, as if she was never cooking, as if she wasn't using her stove. they start looking around the house and realizing they don't see a whole lot of like dishes in the sink or pots and pans that indicate that any other cooking was going on. And eventually they started peeking in her fridge and kind of looking around when they were there and realizing that her fridge, it's clean, it's not turned on, it's not cold at all, and it's full of boxes and boxes of her various injectable diabetic medications. Prescriptions getting filled, but it doesn't look like she's taking or using her medications. And it took a little bit more digging and some good interviewing skills to realize that diabetes wasn't really her problem. She had an adult alcoholic son living in her basement who, whenever he got drunk, would, beat the crap out of her, or at least scare her really, really badly. Her stove had been broken for a number of years. Her refrigerator had broken 6 or 8 months before. She was on a fixed income. And really what that turned into was someone who was eating shelf-stable packaged foods, very low quality, high carbohydrate, junk food that didn't need to be stored in cold, didn't need to be cooked. And she was afraid of her son. And by going to the hospital and by letting herself get to a point by not actively managing her diabetes, she felt unwell enough that she could justify in her own mind her need to leave the home, her need to go somewhere safe. Because when she went to the hospital, she got 3 hot meals a day. She could shower and feel safe. She could sleep at night and not worry about something happening. People were there to help take care of her. And by realizing and recognizing that the problems in the home indicated a problem other than a clinical one, that the clinical problem was really not the driving factor or the driving force, and helping her get connected to a number of resources to address some of those other social determinant issues, some of those other environmental factors, she was able to reprioritize the management of her health and her diabetes. She didn't call 911 and go to the ER anymore because her blood sugar was wildly out of control. She wasn't getting admitted to hospital over and over again. And she was able to focus on prioritizing her health and her wellness. And those are the kind of insights that, while I can't say that it's impossible someone would have picked up on in another venue, without walking into her home, it wouldn't have been as apparent or wouldn't have been as obvious. And that's something that our paramedics are trained, experienced, educated to do. They walk into uncontrolled environments over and over and over again, and they're pointing at the problems. Even if they're not the solution to those problems, their expertise is at walking into that uncontrolled setting and looking around and saying, I see pain points, I see issues, I see complications, I see things that need to be addressed. And that's really what it takes us to what we're talking about here. So 2 terms floating around. One is mobile integrated health, the other is community paramedicine. They're often used rather interchangeably, and really they represent 2 different things, part of kind of the same spectrum. MIH is a pre-hospital care industry-derived term. We paramedics made this up, but it's a way of describing, as an umbrella, all the different ways that we touch patients. And I'm going to start with that definition. We are talking about patients. These are people who are experiencing either acutely or in the near future, or possibly just resolved some type of medical issue that needs to be addressed. So these are patients that are not in the clinic and they're not in the hospital. They're not in our space as healthcare professionals. They're out in the community, they're living their lives. So we're talking about all these different ways we touch folks. And I'm going to set aside 2 specific groups because they're really well-defined and well-regulated in other spaces. So the first are going to be people who are experiencing skilled needs. This is not home health. Home health is very, very well-defined. The regulations exist, the legislation exists, the definitions exist from CMS on down. We're not talking about home health care. Home health care is addressing those specific skilled needs. There's a lot of interoperability. There's probably some overlap, and I often find that when MIH programs build a good program, they build the professional relationships they need. It actually enhances our ability to get home health to people who need it. It's certainly not a competitive relationship, though if leaders don't choose to engage in the relationship building they need to early on, very often it can seem like there might be some competition here between home health and MIH. They absolutely should not be, because we're not talking about delivering home health services. And I'll get into some more nuances why. The other group I'm going to set aside are people experiencing emergencies. We have a very robust doctrine around emergency response in this country, though, again, as you're well aware, in some communities, there are better and more readily available emergency response resources than others, but we're not talking about responding to emergencies. Yeah. For those who are less familiar with EMS, this is kind of a very, very general overview of what the profession and the professional development looks like. And it really, if you look at the middle of the page, the bolded line where it says a paramedic with 2 to 4 years of education plus experience as an EMT or AEMT, we often really look at that line or that level flowing from the top of the page to the bottom as the entry point to being a healthcare professional. We see a lot of the EMR, EMT, AEMT stuff that goes on out there as more technician level. These are people who are prepared through training, and they often have secondary duties. They often work in additional roles. They may be firefighters, they may be police officers, they may be lifeguards, they may have another responsibility somewhere. But those folks are trained. The paramedic, in theory, is where the education level gets in there, and we really start to see more of that semi-independent decision making. We see some professional responsibility and autonomy for practice, and that's growing and it's changing, and there are a lot of conversations happening around it. But if we think about the paramedic as the professional entry point, that's where many, if not most, of these MIH models, and specifically the community paramedics that work within them, that's kind of where they start. And once you're a paramedic, post-qualification, there are a lot of opportunities for specialization. 3 to 5 years post-qualification as a paramedic at a minimum is the norm. It's pretty typical. Again, there's no hard and fast rules. But as a paramedic, the primary specialty in paramedicine is emergency response. So if we start using some of the language more familiar to the rest of healthcare, paramedic is really the professional title. Paramedicine is their practice. Their specialty, their primary specialty is emergency response, but there are a number of subspecialties beyond emergency response. So this could be medical transport. This could be critical care transport, both ground and air. It could be working, again, in the dive environment. We have lots of dive medics that are out there that are trained in hyperbaric medicine. We have the tactical and the military law enforcement and special operations stuff where they're really getting into more mission sustainment skills. Folks that really specialize in like racing and motorsports, and community paramedicine. Community paramedicine is one of these new novel specialties or subspecialties that exist in the world of paramedicine that we've seen emerging here in this country over probably the last 15 to 18 years. I don't think we're quite at the 2-decade point in practice. So that's really what we're talking about here is, MIH is the umbrella. Community paramedics are one aspect or one element that falls under that umbrella, which might include other things like nurse triage lines, community and senior health fairs, in the fantasy world where they still exist, the mobile clinical social workers, and all the different ways we try to get out in the community to touch people and connect with patients. If you can't describe it with a Venn diagram, can you really describe it? I laugh and I pointed this one, and this does not mean that MIH and community paramedics are at the center of the universe, but really it's kind of showing they function in a role that intersects a lot of different professional disciplines. And pretty typically that's paramedicine as a whole and public safety as a whole. If you ask yourself, what is the thing or what are the things that paramedics are better at than anyone else, than any other discipline? And I realize that's a very bold statement. The vast majority of things paramedics do they are educated and trained to perform, someone else is far better than them at. But the one role that paramedics are the experts at, the preeminent experts at, is that assessment of an uncontrolled environment across many domains: structural, environmental, social, clinical. Lots of other folks are probably more expert at lots of those pieces, the things that paramedics do every single day. And I'm not even referring to community paramedics. I mean, just paramedics, is they walk into those uncontrolled environments and they look around. All right. Just mentioned, I actually just threw this slide in there during the introduction, scope versus role, because this comes up very often. Scope is defined by law. Scope of practice is that thing that says in your regulatory, documents, what have you, every state's a little different in the way they approach it. But the scope of practice is often defined pretty clearly. And many people are thinking about community paramedics as delivering an advanced or an expanded scope of practice, like they're doing additional skills, providing additional clinical interventions, possibly becoming responsible for clinical decision making that they would not normally be able to in their more traditional roles, say emergency response. And while there are certainly elements of expanded scope as part of the conversation in places where expanded scopes have been implemented, most of what we're talking about with community paramedics is a deployment of a type of professional, a paramedic, into another role other than their traditional emergency response, without necessarily altering their scope. Every CP, every MIH program is developed to meet a local need, a local identified gap or challenge, and that means that we see a lot of different structures for programs around the country. Some of them, there is a perceived need to fill in a gap in scope or capacity. A lot of the early rural health conversations around MIH and community paramedicine were really focused on that idea of extending care, especially primary and urgent care, into medically underserved rural communities, into those health deserts where people are an hour or more from a primary care physician and don't have good access to it. And how do we leverage the folks that are already there, the paramedics, to delivering additional expanded scope services to the people who live there? And while there are certainly needs for that, one of the most profound statements that I've heard about why it is we do what we do came from one of the CPs that works on my team. She and I have a long, almost 20-year professional history together. We were flight medics together for a long time. And I got a text message from her one night at probably 1 or 2 o'clock in the morning. And she said, it would have saved so much time over the past year if I spent my energy figuring out why people are not connected to the services and resources they need than figuring out how to give them or deliver those services. Why do these barriers exist? Why is this patient struggling to connect to the actual experts? I joke a lot about wound care. Wound care is one of those things that people bring up very often as something that community paramedics could do. They could go out and provide wound care services in the community. And my response to that is very often, when was the last time you heard a paramedic talk about protein consumption as part of a wound healing process? And the answer is probably never. That's not something that's part of a paramedic's traditional education, training, or experience. It's not to say that they couldn't learn it, but most of the time, my answer is going to be, why would I invest in training a paramedic to deliver a specialized form of care that is already better delivered by another professional, when it's probably more effective for me to utilize that paramedic in their expertise to understand, number one, is that actually the problem here? Is the problem that this person needs wound care, for example? And then second, as a follow-on, well, if they need wound care, why aren't they receiving it? Why aren't they connected to it? And in some cases, especially in the rural environments, the answer may be there are no wound care services or mobile wound care services available. The nearest wound care clinic is an ambulatory outpatient clinic, but it's an hour drive away, and this person can't drive themselves, so they don't have reliable access to transportation. Okay, then I'm still going to come back to the root of that problem is not that wound care services are unavailable. It's that this patient is experiencing a transportation barrier. They don't have consistent, reliable way to get to the appointment they may need to. And that is a more appropriate problem to solve than it is to throw a bunch of gauze in a bag and take it to this person's house and wing the clinical care. Now, is there an opportunity for some gap care to ensure that while we're trying to sort out the transportation issue, this person is not just suffering at home? Quite possibly. And again, in a rural community, that may be very necessary due to the lack of actual resources. But scope versus role is a challenging question to ask and answer. Very often, the solution for a CP is to employ them in a new role and not to necessarily battle the expanded scope, because that requires a lot. It's a big uplift to change your scope of practice. And the question is often going to be, well, why would I use a paramedic for that when I already have The other big question we often hear is what's the difference between community paramedicine or mobile integrated health and case management? And I think I kind of brushed over it a little too briefly, but MIH is the umbrella and generally represents like these multidisciplinary or polydisciplinary teams that include community paramedics and are in many cases are led by community paramedics. But an MIH team probably requires some other folks to be involved. You know, example from my program, and again, I'm a large major health system based program, but I have a pre-hospital behavioral health specialist who happens to be a paramedic, a trained community paramedic, and also a PhD prepared licensed clinical psychologist. So she has a really interesting background to help us really enhance our mental health understanding of our patients. She doesn't provide therapy, but she definitely takes the standardized screening tools that we use as CPs and is able to say, hey, this person is experiencing a whole lot of mental health barriers to wellness or barriers to caring for themselves. Let me dive in more deeply and help them resource. And she's really well plugged into the rest of the health system to kind of help make those referrals and connections. You know, we have a pharmacist on our team, and that's a whole other conversation, but the impact of a pharmacist on an MIH team is I don't want to say it's incalculable because the data is definitely there that it really does matter. You know, we've got physicians, we've got data people, we've got other types of professionals. Many programs use community health workers, they use social workers, they use dietitians or nutritionists, all as part of that effort to really enhance what they're doing and make sure patients are being resourced appropriately. But the difference between case management and the MIH approach is that case management starts with a label. You can call it a diagnosis, you can call it something else if you like, but at the end of the day, it's a label. And we start with that by saying, hey, this person is a hip replacement patient. We've labeled them as a hip replacement patient. And we know based on history, evidence, I hate calling it evidence-based, but I can certainly call it evidence-guided, that if someone has a hip replacement, if they check a series of boxes more or less in order, the data says that that patient is most likely to have the best outcomes. So they're really starting from that idea of let's start with the diagnoses, let's start with diabetes, let's start with heart failure, let's start with stroke, let's start with hip replacement, and apply again that historical evidence that says follow this path, you're going to have the best possible outcomes. That's the care path or the care plan approach to things, and that's the one that's most familiar to health leaders and administrators. They're used to the case management approach to things. Arguably, community paramedics and MIH should really be looking at the same patients, or at least a subset of the same patients, but from a different perspective. I don't care what your label is. It's kind of unnecessary or irrelevant because I'm not here to treat your heart failure. I'm not here to provide physical therapy for your hip replacement. I'm not here to manage your diabetes or educate you about your diet. What I'm looking for are those patients that I can recognize that their utilization, that their demand for services, that their burden on the healthcare system is disproportionate to what we would expect. The 5 diabetic men in their 50s, 4 of them are very well managed. A1Cs are, in an acceptable range. They've got a PCP, they've got an endocrinologist. They get all of their recommended testing every year, and maybe every 3 or 4 years, they have a little blood glucose emergency. They get up in the morning, take their meds, don't eat breakfast, go work in the garden. It's 90 degrees and 90% humidity, pass out. The neighbor calls 911. You get there to realize their blood sugar is low. We fix that. They wake up, they're embarrassed. They refuse to go to the hospital. That's what we expect from a well-managed person who has diabetes. But that 5th patient is calling 911 over and over and over again. Their blood glucose is wildly out of control. Their A1C is, 2 or 3 times what it should be. They're hospitalized annually, sometimes multiple times annually, often in DKA. They don't have an endocrinologist. They haven't seen their PCP in a couple of years, and their PCP is uncomfortable refilling their meds now. They haven't had any of the screening exams that they really should have had, and they're starting to experience some of the long-term effects of poorly managed diabetes. The difference between that 5th person and the other 4 is not diabetes. Diabetes is diabetes. The difference with that 5th person is all of those psychosocial and environmental factors, those social determinant issues. And the people most appropriately positioned to observe those things are paramedics, and better community paramedics with the specialized training, the language to articulate those things and to help them connect to the right resources and programs and services to address it. Again, every CP program is designed to address a local need. So if you're starting one, you have to start with this question: what problem am I attempting to solve? And I'm going to kind of admonish everyone to say, think bigger. Because if the problem you're looking to solve is, frequent 911 utilization, the people who write big checks for this stuff don't care. EMS calls are a rounding error in most health payer budgets. If your problem is 30-day readmission rates, again, that's an artificial metric that was created under the Affordable Care Act that really doesn't have a lot of science behind it. And what happens when that changes, when the disproportionate incentives go away? So think bigger. Who else benefits from a patient more effectively, more efficiently using healthcare services? So the other big thing that Nicole asked me to really talk about, and it seems like I keep getting asked to talk about it more, is data. Data. And I did not come at this as a data geek. I definitely came at this as a practitioner. And over the years, I've learned that we have to start paying attention to data. And it's not just a matter of collecting a bunch of random things. It's about understanding how we tell stories. And data allows us to tell stories that health leaders, that community leaders, that stakeholders want to hear. The data from the work you do, whether it's traditional emergency response or all of the MIH work, is possibly the most important thing and the most valuable thing that you have. As kind of my mentor, a guy by the name of Dan Swayze, who's a paramedic with a doctorate in public health, who's really one of the early thought leaders in community paramedicine, reminds everybody on a very regular basis, EMS, we own the 911 call. We know who the people in a community who are picking up the phone and engaging the safety net are, and no one else does. No other stakeholder in the healthcare side of things knows who's calling 911. We do. And you can ask any medic on the street, generally within about 30 seconds of walking into someone's home or walking onto a scene and looking around, they know whether or not they're going to be back again. That's that professional, gestalt that you develop over not a lot of time. You learn to walk in and look around and realize this is someone who is struggling with something, and this call probably didn't need to happen. Community paramedicine is taking that realization, that understanding, and putting them in a role where they can do something about it. Because on a normal 911 call, they're time constrained and they're resource constrained. They're going to treat it like an emergency because that's how that person accesses the system. Community paramedicine removes the constraints of the 911 call and says, let's sit down and figure out what this problem is, figure out what it is you're really, trying to do, what matters to you, what barriers are in place, and how do we get you better connected. Uncertainty is risky and expensive. If your data is not good, your data doesn't explain or document what it is that you're doing, that creates risk. It creates gaps because you can't actually point to and say, this is a driving factor, this is a causal relationship, or this has strong associations with these type of outcomes. Being able to explain those unknowns, that uncertainty, do we know if the work we're doing makes a difference? We've got to be able to explain that. A hard-learned lesson. Collecting data after the fact is hard. It's hard, and the data you do manage to acquire is going to be of poor quality very often. Because going back and trying to create a system to retroactively capture things is nowhere near as clean as making sure we're building good collection systems to answer questions. You got to ask the right questions, and this is how we tell our story. So going back to that first patient I described, how do we tell her story to stakeholders? How do we tell her story to, say, the Medicaid folks who maybe want to start funding or reimbursing or creating a revenue stream around that, or commercial payers or local hospitals or local physician groups? Again, how do we tell this patient's story and our involvement with it in a way that incentivizes them to support it? What did we do? Okay, well, what we did is usually where EMS starts and stops. What did we measure? What metrics were we tracking to help us illustrate change? Are we tracking A1Cs? Are we tracking frequency of 911 calls? Are we tracking, what are we tracking? Are we tracking whether or not she fills her prescriptions? Are we tracking whether or not she's taking her meds? How would we get that information? And what changed? Who we connected, again, kind of an intermediate metric, because just because we make a connection or a referral doesn't mean it actually delivered an outcome. And that's unfortunately one of the things that comes up a lot in these social service type programs, especially the limited term grant funded ones. People are really interested in, well, how many referrals did you make? How many connections did you make? But that really doesn't tell us whether or not it fixed the problem or to address the issue that it was identified. So it's kind of an intermediate objective. But can we structure the way we record this stuff so that from patient to patient, from phase of project to phase of project, or even from project to project, we can make those real comparisons? And that's a hard question. But this is the work we have to do right up front when we start talking about successful MIH programs, or really anything. It's not about the work that you're doing, it's what you're accomplishing. And that's a point I keep coming back to over and over again. And that's one that got beaten into my head very, very frequently, very often, and still does. Because the big picture stakeholders don't care what work you're doing. They care what you're delivering, they care what outcomes you're producing, or you're at least strongly associated with. And can you prove that association? You've got to, again, every MIH program, every CP is a local solution to a local problem, but you have to ask the question, what are you trying to solve here? And then again, be able to tell that story. And now that I've got kids, I got to say, answer the 8-year-olds questions, because 8-year-olds are going to ask these incredibly painfully exposing questions that you wouldn't even think about. But if your 8-year-old can ask the question, so can the stakeholders that are really interested in why they're investing the time and money in this program. Well, why did you do that? Well, why doesn't she just move? Well, why is her son mean to her? I mean, those are the kind of questions where you're suddenly stuck and stumped. You're like, well, I don't know. We never asked. All right, fatal assumptions. And this is one I'll come back to pretty often and leave you with here. Folks in EMS, folks in public safety in general are really grown up in a public utility model, and they make 2 assumptions that are completely BS. But we often believe that our value is inherent and that it's self-evident, that it's obvious that we're valuable. It's obvious that we do good things, and that, how could you not see and understand that, well, we're good, we're a value and a benefit to the community. We're an important, part of whatever's happening here. And being challenged on that is something very uncomfortable for EMS leaders. It's something I think for all of you in your roles, maybe in one of, if not the best position to help mentor and advocate our EMS leaders who are getting involved in some of these different efforts and programs, push them to go beyond this, assumption that they are valuable because they exist, that, we should be getting paid for showing up, because that's not really the case. And we're starting to be held accountable for that more and more often. And especially as healthcare in general starts moving more to value-based revenue models, where the accountability is for the outcomes and not just the work done. The fee-for-service model is kind of going away, fighting and kicking and screaming, but it's starting to go away. Our EMS leaders are going to have to become more comfortable at having this conversation, being able to talk about what our value is, what not only the return on investment, but the value on investment looks like, and how we integrate into the bigger picture. So I will leave you with that and pass it off back to you, Nicole.
Thank you, Jonah. There is a reason I keep asking Jonah to talk to anybody I can get gathered onto a Zoom call about data, and it's because of the way he articulates it. I am one that doesn't love to work with data. I am definitely not very skilled at it, but to hear Jonah talk about it, it just makes so much sense about why it's important. So there's a reason I keep inviting him to talk about data. So thank you, Jonah, for sharing that information. Really quickly, did anybody have any questions for Jonah? Otherwise, we can kind of hold questions until the end too.
And you guys can feel free to type in the chat box or unmute and use your voice.
Oh. Okay, I don't see any mics unmuting, so I am going to go ahead and talk about key strategies for implementing and sustaining rural CP. However, like Keely said, definitely use the chat if you have any questions, and we can continue to address those as we go along here. Okay, you guys see my screen? Keely, you see me okay?
Yep,
Okay,
you're good.
all right. All right. So I'm going to talk about, like I said, strategies, some of the key strategies for implementing and sustaining rural CP. And where I'm getting my information from, this is all based off of a virtual event that the TASK program here at the center held back in February earlier this year. The event was supported by the Federal Office of Rural Health Policy and coordinated by us here at TASK in the center. And I'm really only going to talk about just what I said, key strategies for implementing and sustaining. There is a lot more in that document, and I'll talk about that here more in just a minute, but that document is set to come out any day. Objectives of that summit were to identify challenges and opportunities related to implementation and sustaining, and Jonah talked about some of that, which I had a feeling he would, identified CP models and to capture some of the lessons learned, identify strategies and resources, both existing and needed, including how state flex programs can support related activities. And then we also did some crystal balling about the future of community paramedicine. These are the people that attended. Definitely, of course, not going to say all of their names, but two of those people that attended are here on this webinar today. So we chose those listed on the slide as participants for different reasons. There are a few well-established CP programs included with a mix of urban and rural focus, which is Jonah was one of those. Critical access hospital administrator with an in-house CP program, who you're going to hear from next, that's Joel. And then a couple of state flex programs who have historically and currently support community paramedicine initiatives, and representatives from the flex monitoring team at the University of Southern Maine, who have been evaluating flex funded EMS and population health initiatives, and have also done work around EMS data in past years, along with a bunch of other people. So jumping right into key implementation strategies, when implementing a new CP program, start small and focus on an identified need and do that really well. And then build the capacity to do more. Be careful not to take patients into the CP program that it isn't equipped to deal with. Trying to do too much can cause the CP program staff to become overwhelmed, and then they end up maybe doing a lot, but not doing a lot very well. Community partners are important in various ways to CP. Be sure that the stakeholders all understand the intent and focus of the program. Have a compelling business plan and metrics that matter to you, of course, but also to whoever else is to be involved and invested in the program. And you, like Jonah had talked about, not duplicating efforts with home health, that you definitely want to have synergy and not be duplicating services. Differentiating the CP program from other providers is important so that patients know exactly who is caring for them in their home. One of the summit participants shared that they create a care map for patients and clip their business card to it so that the patient knows that they're not home health or a therapist or some other sort of provider. And then also, again, with data, I'll tell you during the conversations in our summit earlier this year, data came up in every single aspect, every single level of whatever we were talking about. It just kept coming up. And it was knowing where to get data, knowing what data was important, knowing how to work with data, really thinking about outcomes and collecting data that matters and consider who it matters to. Who are you asking to invest in your program? Things that EMS has typically been focused on in the past are not necessarily the things that the stakeholders are going to be interested in. So make sure that you're collecting and analyzing the data that's actually important and not just data that has always been collected. And be sure that you're having the intended outcomes, and if you're not, why? Address those issues so that the program can improve and sustain. Then the last one there, take advantage of the current COVID flexibilities that have emerged to fill gaps left in healthcare. While the public health emergency obviously will not last forever, some of the flexibilities may remain, such as expanded scopes of practice and telehealth opportunities. Our CP Summit participants really saw an opportunity in joining telehealth pilot programs. So moving into sustainability strategies, my opinion, I think the most important one here is to be planning for sustainability on day one. As I said earlier, many programs start with grant funding, and it's wonderful that it's out there. However, grant funding will not sustain a CP program. It just absolutely won't. You know, as you know, with flex funded projects, they may be a year, they may be 2 years or 3 years, but then after that, you know, hopefully the flex program in this example is helping you think about sustainability, but they might not be. So that's just something you absolutely can't count on as a way to sustain your program. One of our summit participants said, and that participant was Jonah, spoiler alert, who you heard from earlier, start telling your story and collecting meaningful data right off the bat. Finding funding sources is imperative. Convincing payers has been slow, but some programs have found inroads with that. Not all state Medicaid reimburses for it. So
we're going to take over managing.
So at least CP in Minnesota has that going for it, and that Minnesota Medicaid does reimburse for that. And Joel can give you a little bit more information about that. Also, things like emergency triage, treat, and transport, or ET3, and community health access and rural transformation, or CHART, those pilot models coming out of CMS also expand possibilities for rural EMS and CP to affect care. Care transitions and hospital readmissions avoidance are a couple of financial strategies that create opportunity. But again, as Jonah said, you can't really put all your eggs in that basket, because if something changes at the federal level related to that legislation, you know, that can cause some problems. And then data, again, it absolutely needs its own focus. Definitely, you know, find out from other established CP programs what they measure, why they measure it, see how it applies to you, but don't necessarily copy, paste, and go with that. Network and learn from those that came before, but be sure that you really consider the needs of your effort. In the summary document coming out soon, there are some measure sets to consider and work from included in the resources section. There's also some social determinants of health information and projects in those resources that you can take a look at when the document comes out. And then another strategy not listed here is just to be open to opportunities. Consider all the ways that CP can affect and improve care. Have a grand plan, but remember to start small and build the capacity before taking on a bunch of things. I think I missed a slide. Okay, so like I said, the summary document is expected to be released here any day. In addition to what I just shared with you as far as some of the key strategies go, all of those objectives I shared earlier, there will be information, more in-depth information about those things. Examples of current models of CP, existing CP resources in various categories and such. So if you are interested in getting a hold of that document when it comes out here in the next few days, feel free to send me an email directly and I will make sure that you get it. Otherwise, it will be disseminated to state flex programs and state offices of rural health and some EMS listservs and such. But if you're not sure that you'll get your hands on it, definitely feel free to send me an email. I'm happy to make sure that you get a copy when it comes out. So that is it for me. And now I see Ted left me a message in the chat, so I'll check on that. But I want to turn it over to Joel just to talk a little bit about his experience with community paramedicine in his hospital. So Joel, go ahead.
Thank you, Nicole. And Jonah, you know, this is now the third time we've got to spend a little time together, and I always find the great insight and the passion that you show and the immersion that you've got in the program. So good morning, everybody. I'm happy to take a few minutes here today, and I'll keep mine fairly short from a strategic level. But first, a little background on Tri-County and our involvement in CP. We have been the local EMS provider here since 1988, when we took over what was at that point a county-supported, privately operated EMS service that was on the verge of failure, quite honestly. So we really had a need as the community healthcare system to jump in and say, if we don't do this, nobody will, and it won't be done well for the community. So there's a real gap coming. Fast forward to the mid 2000s, so 2005, 2006, I don't remember the exact date. Our EMS manager at the time was very involved in the state EMS activities, learned about the CP program that Hennepin County was doing, which is a large metro county in the Twin Cities. and thought, we could adapt this here and there's some value to it. But at that time, the biggest potential value was it was a way to actually generate some revenue for what was otherwise sunk time, basically unproductive time where our paramedics were on call. And we saw an opportunity that, hey, they could use that downtime to do some things and actually generate a small amount of revenue from our Medicaid program as they created Medicaid reimbursement that Nicole referenced and continue to this day here in Minnesota. I will say for us, until about 6 years ago, the program ebbed and flowed based upon the leadership, based upon our financial resources, based upon just various strategic factors. But about 6 years ago, we entered into what we call our value-based care initiatives. We started to get involved with a regional healthcare system that was developing a clinically integrated network system that we are very involved with in a number of factors, and jumped in then to a Medicare shared savings program. So our ACO development, we are now in our 5th year as being part of a Medicare shared savings program, in our 2nd year in an at-risk model. And you go back also to that 6-year time frame is when we started to develop our care management and care coordination programs, really around the idea of value-based care. So my advice for other hospital administrators is, I see for us, that's really probably the biggest potential value here, is it is a tool in the toolbox as far as managing value-based contracts. Things like the frequent flyers in the ED, keeping folks well from a standpoint of not needing excess primary care visits, where they come to their doctor every week for something that could be handled in a more in-home kind of model where they don't qualify for home care. That's really what we see as the value. I use the phrase that for us, the community paramedics, one of their jobs is to be the boots on the ground for our care coordination staff. So the RNs who are working closely with the panels of patients that they work with in various diagnoses. Jonah used the term labels, that's certainly part of how this works and doing that case management. And I think in a lot of ways, that's been the value. I will admit I've learned a lot from Jonah listening to him now from the February summit and now again today, that we could do a lot better job in terms of our data. No question about that. There's a lot we're going to learn from the release of the community paramedic report that Nicole talked about, despite having a long history with it. But the strategic value really for me is that idea of managing long-term case exposure. And for anybody who's seen the very recent news coming out of United Healthcare, this sort of stuff is going to get even bigger, where they're talking about retrospective denials on emergency care. That sort of thing will come. Even if it doesn't take hold now, it will come someday. So we'll have to make sure that we are managing not only the ED, but every avenue of care that we can. But in a lot of cases, I think, and I'll close with stories. As Jonah said, I think sometimes stories tell the best evidence of where the value can be. And 2 of my most telling stories around the value of our community paramedic program are these. One, we had a patient, in the 70s, COPD, spent some time in the hospital, got discharged. It was the 2nd or 3rd stay in the course of a year. Got referred into our care coordination program very appropriately, made all those connections, home on oxygen, of course. And one afternoon, woke up from his afternoon nap, unable to breathe, picked up his phone, was going to call 911 like he typically would do, but saw by the phone was this business card for that young gal who was the nurse care coordinator. Said, oh, I'll call her instead. Did that. They got the community paramedic out there. In 15 minutes, we realized that his oxygen concentrator had somehow gotten disabled. That's where his breathing was coming. So in the course of that one experience, we avoided a 911 call, certainly an ER visit, probably an inpatient stay, and who knows, maybe saved his life. The value to that patient, the value to the care system, to the payer system, very measurable, very real, something that we can put an absolute value on. The second story is a bit more esoteric from a standpoint that it's hard to gauge the value that we generated, other than the fact that it's a human life. So a very frequent flyer in the ED, one of those patients that everybody hated to see come in. He was usually coming in via law enforcement transfer, and violent, someone that was dangerous, not only to others, but to himself. And this goes back about 2 years ago now. One of those visits, law enforcement met with our nursing staff and said, pretty soon we're going to quit being able to quit dealing with this guy because he will be dead. And the assumption there was that it would be death by law enforcement was the assumption. And we connected him with our community paramedic program. Turns out that his bipolar disorder, which would needed to be treated by various medications, we found the absolute best treatment working with our physicians who are engaged in it, that there was a once a month injection that would actually provide the necessary treatment for him. So our paramedics made the personal connection with him, got to know him, and developed a trust where he would come to us or we would go to him. I'm actually not quite certain how they arranged the logistics on it, to assist him with that injection. And it was about 18 months later, so 6 months ago, kind of middle of COVID, in a meeting with the local law enforcement, they said, well, whatever happened to Joe, I'll call him. And said, we assume that he left the area because we haven't seen anything from him now for more than a year. And the answer was no, Joe is here, he's fine, we see him every month. That's the value of the community paramedic program. So I would encourage folks to look hard at it. There's great value, especially if you're entering value-based care initiatives. And there is actually some revenue stream associated with it. We get value not only in actually generating revenue, managing the costs. For us, besides the Medicare ACO, we also have a Medicaid integrated health partnership contract where the community paramedic is a very active piece and very visible piece as part of that whole program that we're involved with there. So I think I'll pause there, knowing that we are close to out of time, Nicole, and happy to entertain any questions along with the other speakers here today.
Yeah, thank you so much for bringing up the stories. I didn't mention that when I was talking about how important data is, but you will see in the summary document, if you get your hands on it, that it also does talk about how stories are just as important as data. They both have their context where they are very important, and stories are invaluable. I think just as invaluable as all that data collection and being sure that you're showing your outcomes and knowing where you need to improve and that sort of thing. So we have about a minute left if anybody wanted to unmute their mic and ask a question. Otherwise, I will turn it back to Deb and Keely.
Yeah, as people are doing that, thinking of their questions, we do have a few closing poll questions. So Keely will be putting those up in the meantime. We'd like to thank Nicole, Jonah, and Joel for attending today and for being part of our webinar and giving us such great information. And I want to thank you all participants for attending today's webinar. The webinar's recording will be posted on the center's website, and you'll be provided with a link that you can pass off to other people in your organization that would benefit from hearing from it. So at this point, let's move into a brief question and answer time, as long as Jonah and Nicole and Joel are available. So again, feel free to unmute and ask your question, or we will monitor the chat box for questions as well.
And then this is just our last polling question.
Thank you, Jonah and Joel, so much for continuing to show up at my events and helping me out. I sincerely appreciate both of you.
You're welcome, Nicole. I'm happy to help.
Anytime. Thanks, Nicole.
Yeah. All right. Well, you guys have a good day.
Thank you all.
Does anyone
Bye.
have any questions?
I just wanted to thank you
One last chance here.
thanks for the presentation. It was excellent.
Absolutely. Email me, Ted. I got stuff for you.
And
Thanks
Carrie,
very much.
Yep.
Carrie, we will be sending out the recording sometime next week, so you will get that.
All right.